Good morning, good afternoon, and good evening to our viewers in different parts of the world. Thank you for tuning in to the South Sudanese Women Intellectual Forum talk show today. It is my pleasure to have this wonderful women with me as the panelists, Dr. Anne, Dr. Alice, and Dr. Sandra. Welcome. The South Sudanese Intellectual Women Forum goal is to have an online dialogue, community mobilization, participation, and to link the South Sudanese professional women globally. We would like to solve challenges facing our South Sudanese women. We strive to empower and educate women to be part of sustainable peace, development, and poverty reduction in South Sudan. We mentor our daughters and sisters to grow. We want to recognize, promote, and also to cheer one another on. My sister's success is mine as well. Welcome, Dr. Jane, to the panel. We today are going to talk about COVID-19 updates, vaccines, prevention, and control with our esteemed panelists that I am honored to interview. We all know that COVID-19 started in Wuhan, China, and then it spread all over the world and became a pandemic. Over 136 million people have been infected worldwide. 2 million people have lost their lives. And at this very moment, I would like to pay our condolences to the family of Dr. Richard Okello, our colleague who passed away in Papua New Guinea. I understand there is a fatigue about COVID-19 pandemic, but the infection is still spreading all over the world. People are dying. There are a number of cases that are increasing. For example, in the state of Michigan in the United States, there is a 30% increase of new cases. In Michigan, 90% of the hospital beds have been occupied. In South Sudan, people are still dying. So we know that COVID-19 is real. الليلة هنتكلم عن COVID-19 هنتكلم برضو عن التطعيم والغوانين الخدتها والحكومة بتاعنا مع الدكاترة بتاعنا دكتور آن، دكتور ساندرا، دكتور أليس ودكتور جاي. Without further ado, I would like to introduce our panelists. We have Dr. Anne Lamule on my far left on the screen. She is a pediatrician and also infectious disease consultant. She has masters in pediatrics and child health. She has a postgraduate diploma in tropical medicine from London School of Hygiene and Tropical Medicine. She has worked with the Ministry of Health in Yei, South Sudan, Médecins Sans Frontières, in the capacity of a medical coordinator in Juba, Central Equatoria, Yambio, Western Equatoria State, Raja in Western Barghazal in South Sudan. In the same capacity, she has interacted with various international agencies involved in related activities and planning in the South Sudanese health system in South Sudan. She is currently based in Kenya and works with Gertrude Children's Hospital in Nairobi, Kenya. She has a passion for infectious disease control and child health. Welcome, Dr. Anne Lamule, to the panel. We also have Dr. Sandra Banks. She's a graduate of Juba University School of Medicine, served as a medical officer in Juba Teaching Hospital, was an assistant lecturer in surgery department at the University of Juba College of Medicine 2010 to 2018, was part of the National South Sudan Cholera Outbreak Response in 2017, and also the Ebola virus preparedness and readiness with South Sudan Red Cross, supporting infection prevention, control, and risk communication and community engagement. Previously, she was also Miss South Sudan. That is something great. And hosted health education sessions primarily on radio with the aim of increasing the community awareness on endemic diseases and means of infection disease prevention. Dr. Sandra Banks will cover the public health response statistics and vaccine rollout today. Welcome, Dr. Sandra. With us also is Dr. Alice Ladu. She is a medical doctor and a public health specialist with a master's in public and tropical health. Currently, she's working with the World Health Organization emergency program for the last 6 years, with experience in preparedness and response to outbreaks, for example, measles, cholera, and COVID-19 as well, and other preparedness activities in the capacity since 2005. Dr. Alice will cover the surveillance. So welcome to the panel, Dr. Alice Ladu. It's a pleasure to have you with us. Last but not least is Dr. Jane Abuja. She's a professor of nursing and clinical and classroom instructor for the Carrington College of Nursing Associate Degree Program in Phoenix, Arizona. She earned her degree in 1988 as a nurse practitioner, and prior to moving to the US, a degree in medicine. In the US, her 2 degrees were not recognized, and therefore she had to go back to school and later earn a bachelor's degree in nursing science and a master's degree of science and nursing with specialty in acute care as a nurse practitioner from Grand Canyon University. She currently holds a doctorate of nursing practice. She received numerous awards throughout her education career, including Outstanding Achievement from the Government of South Sudan for mobilizing the South Sudanese community and the Sudanese community as well. The Living Legend Award for Community Service, Heart of Gold for the NAACP. She hopes to open a local clinic of her own to treat patients suffering from heart failure, a research topic she became passionate about in school. Dr. Jane will cover the diaspora situation update. Please, I welcome all of you to the panel. And with that, I will start with Dr. Sandra. I will start with you. Take us through the pillars of COVID-19 response in South Sudan. What are some of the public strategies that have been shown to work, and which of these are being implemented in South Sudan? Over to you.
All right, I will say good afternoon, since it's afternoon, early evening on my side, but as well good morning and good evening to the rest of our listeners and those following up on this conversation. Thank you for joining in. So with regards to the South Sudan COVID-19 response, initially it started as a preparedness effort, which later converted to a response effort. So we have what was developed in early February, March 2020, which is what we call this the South Sudan National COVID-19 Response Plan. And that plan unfortunately lapsed just March this year. But however, through this plan, we were able to control the outbreak and ensure that all the intervention methods and intervention activities that were requested or that were foreseen were actually implemented, even though it was not optimally implemented. But what we can say is that we have seen South Sudan go through 2 waves of COVID-19 outbreak or epidemic. We had 2 waves, and we were able to manage to go through these 2 waves successfully. So we have 8 pillars in the national COVID-19 response plan. We have the first pillar, which is the overall country coordination pillar, and this is more of a higher level strategic decision making, policy making, resource mobilization kind of body, which also is reflected at the sub-national or at the state to the county level as well. We also have the the risk communications and community engagement pillar, and this pillar focuses on ensuring that enough community awareness is created to change or to induce a positive behavior change amongst the communities. I'm specifically focusing, of course, because it's COVID-19, on the different preventive and protective measures with regard to the public health and social measures that are being put in place. We also have the case management pillar, and this pillar is specifically focusing on managing of cases or individuals who have contracted COVID-19, and we have different different mechanisms of managing cases. 2 of them was admitting cases who are moderate to severely ill in isolation centers, and this has happened all across the country. But fortunately, most of those who contracted the disease were not severe. They just developed mild symptoms, and almost 80% had no symptoms at all. So these were being monitored under what we call the home-based care. We also have the infection prevention and control pillar, which also works closely with the case management pillar. And we also have the surveillance pillar, or what we call the case investigation, surveillance, etc., which includes the different response teams, whether it is the rapid response team at the national level, the state level, whether it's contact tracing teams, whether it is mortality surveillance teams as well. And then we have the logistics pillar to ensure that all the necessary supplies and commodities that healthcare workers or what we call frontline workers require are actually delivered to their different locations, and that basic needs such as thermometers, personal protective equipment reach all the 80 counties across all the 10 states. And then we also have the data management pillar, which was recently introduced just at maybe the last third of the outbreak. And this is to ensure that we are managing all the information we're getting from the different locations. So overall, we have 8 pillars managing the response. Of course, at that time, the vaccines pillar was not part of it. The vaccine technical work group was just recently introduced towards the end or the last quarter of 2020 when vaccines became more available. So these are the different pillars that were established, of course, through the guidance of initially what we call the National Steering Committee, which is the operational body. It's technical and operational, and where we have not just the Ministry of Health leading, but you also have the different partners across the 10 states who are supporting the COVID-19 response, whether they are INGOs, UN agencies, or even national NGOs as well. And we also have, of course, the National Steering Committee, which is also being overseen by the National Task Force, which was previously called the High Level Task Force. As we've seen around the world, that COVID-19 is really a big thing, let me say. But given the rapid spread of the pandemic, we needed higher level and political intervention as well. So in most countries, we've seen national task forces, or the main task force leading the country is either a senior ministry or some sort of office in the presidential office as well, which we have in the country here. So the National Task Force is overseeing the overall country response, which is being supported by the different pillars, of course, under the leadership of the Minister of Health. And we also have the Medical Advisory Panel, which supports by giving technical guidance as well to the National Task Force and to the Steering Committee. So we have different bodies and different pillars in their different capacities supporting the response. And I think we've had several communications that were sent out. Of course, these are all strategies that were guided by the outbreak, by the dynamics of the outbreak we've had in the country. And we've had public health and social measures that were being put in place. So through the different partners at the state level and the county level and the BOMA level as well, we also have, because most of the outbreak or most cases of the outbreak were seen in actually Juba, were seen in the capital, but this is expected given that the population density is very high in Juba. So we've seen through the National Task Force that the public health and social measures that that have been put in place were actually being implemented, even though they were not. There was a large non-adherence and non-compliance by the population to sticking to those public health and social measures. Yet again, most institutions we've seen have actually been applying it. So some of them was ensuring that all individuals leaving their homes, going to crowded places, are wearing a face covering or a cloth face covering or a mask. So if you don't have the medical mask, you can have this normal mask that is made out of kitenge, for example, or any cotton mask. It was one of the measures that were ensured to be implemented, even though we did see a very small portion of the community actually wearing masks, and there was a even though there were large millions of masks that were distributed, people didn't really adhere to that. But one of the measures that really worked well was the banning of social and public gatherings. So we've seen that the National Task Force and the Steering Committee have ensured that, for example, public transportation would carry people at half the number or half the load. And this was implemented for quite some time. And it did work because one of the measures to prevent COVID is to maintain at least 2 feet from the next person sitting next to you, specifically if you're not wearing a mask or covering your nose and mouth. So having the number of people in public transport really worked well. We've also had banning of funerals and weddings and other public gatherings, sports events, etc. We've seen closure of schools and universities. So all these different measures actually did contribute positively to controlling the outbreak. Because of course, when you limit the number of people who are exposed to the virus, you limit the transmission. So these are all some of them, specifically the public health and social measures. It is the #1 key intervention measure that we need to continue to ensure that the public do adhere to it. I know our numbers have significantly decreased, but one of the main problems we face in the country is the non-compliance by the community, and people still don't want to believe that COVID is real, that it's here. When they see someone wearing a mask in the street, that person is stigmatized. That person is called Corona. Our partners doing the social mobilization and the community engagement are trying their level best to ensure that that community awareness is ongoing. But we also do ask the public to do believe that COVID is real. One of the reasons that this may not, people may not be taking COVID serious in our country is our very low death rates. Since the beginning of the outbreak, we've only had 114 deaths. Our case fatality rate is 1%. So because we have very low numbers of people dying, people don't think it's a serious threat. And this ignorance is actually, this ignorance could be the biggest enemy that we're actually facing, other than the virus itself. So maybe just to wrap it up, in summary, this is some of the public health and social measures that were being implemented and are still being implemented, even though the partial lockdown has been relieved just a few days ago. We can see that people are now, bars are open, restaurants are open, churches and mosques are open. We haven't seen schools open yet. We do hope to see schools open, but yeah, we're just calling for people to try their best to ensure they cover their face, their nose and mouth when they leave the house, to wash their hands with soap and water, use hand sanitizer, and avoid being in congested places. I know that I might have derailed a little bit from the main question, but we can have guidelines written all over the place. We can have, but if people don't comply with these guidelines, we're not really fixing the problem. This is why I just wanted to really touch on the very high non-compliance by the community, and to call for our people to ensure that they do stick to these preventive and protective measures. Over to you, Dr. Okot.
Thank you, Dr. Sandra, for that elaborate explanation about the pillars. And you have touched in the second question that I was about to ask you regarding the challenges and what are some of the things being put on place. So I'll go to the third question, which is I was in Juba in January, and I had seen a lot of people not wearing masks. Funerals were going on in spite of the rules that were being put. Buses by then, in January of this year, were already on full capacity. The middle chair was not empty. I went to Konya Konya Market and the places were full. So the challenges you are talking about are real. What is the government doing to make people wear masks, to stop people from going to occasions? I even heard that people have to ask permission from the vice president to have weddings. Why do we put rules in place and then still go back and ask the vice president, who is from the high level task force? What do you do with such a challenge?
It's a very good question. It's very important that we do notice and we do realize that you can. It's just like the last point that I made. We can have guidelines written all over the place, but if we don't apply them, we're not really and truly fixing any problem. So we did see a few times that some of these measures were being enforced. Okay, but these they did not continue for they did not continue. So we saw a few scenarios where we've had officials or armed personnel, let me say, organized forces ensuring that places are closed, tea places are closed, for example, bars are closed, people are wearing masks, but it did not it did not continue to happen. And maybe I'll just I wish that we did have a mechanism in place to enforce these measures. But when you do sit with the people and you do sit with the community, you look at something like a lockdown. We see Europe and Australia and Canada and the United States, people going on lockdown for 6 weeks and 8 weeks. No one is leaving the house. But try to imagine that scenario in the setting of South Sudan. It's almost impossible to have someone to sit in their homes for 8 weeks, or let me say 4 weeks, and they have a family to feed. They don't have any source of income. The salaries are not there. So people do need to leave the house to find ways to maintain and sustain their families. So issuing a complete lockdown or really forcing people to stay in their homes is not a practical solution, given our circumstances and given the conditions that the people of South Sudan are living under. Even me, I mean, for me, I can stay in the house for 2 weeks, but I don't think I can stay more than 2 weeks inside the house, because at the end of the day, you will still have to leave to go get your groceries, to go. What if someone is sick? So people staying at homes is not practical in South Sudan. So we shouldn't also be expecting that whatever is happening in Denmark or whatever is happening in Australia or New Zealand should be mirrored in the setting of South Sudan. Putting the dynamics of the outbreak on one side, that we've had very low numbers, very low mortality rates, very low transmission rates. Putting the dynamics on one side, the social and economic situation does not really favor that people would go under complete lockdown. And it's not like in South Sudan, stay at home and you will get a $600 check at the end of the month. It's not like that. So we did see our government step in a few times to ensure that these measures are implemented. Several places have been closed, and these are things we've seen. Schools have been closed, institutions have been closed. One issue that I do not really maybe accept is giving pass cards to certain activities to happen. Why are we having a wedding in the middle of a pandemic? Why are we having a funeral prayers with over 1,000 people actually attending? We've also seen for some time that funerals would happen, but the national authorities would ensure that people are wearing masks and that there's several hand washing points. I went to a funeral during the time of the outbreak, but I had my mask on. There were several other people, maybe at least 50% of those who were at the funeral were wearing masks. There were several hand washing points. Everyone was eating in their own plate. But still, I mean, it's not the best that we could do. We could actually do better, but it's just the social and economic situation that we have that is just really making it very challenging for us to optimally implement the proper infection prevention and control measures that we expect to see in the middle of such a pandemic. Over.
Thank you, Dr. Sandra. I would say maybe we cannot have a complete lockdown. People need to go out, but people need to be sensible. You go out to the store, get what you want, and come back. Go to work and come back. What I am against are all the social gatherings that are happening in South Sudan, Bikayat, Kanais, and all the other things that people are doing. Weddings are still going on. That is completely wrong. Dr. Jane Abuja is here with us just for a short time, and I really thank you, Dr. Jane, for taking the time to come and answer some questions. Now, I would ask you these questions. A lot of people still have the myth about COVID-19 in South Sudan. Who are the most affected people in diaspora from your experience? And what are some of the risk factors associated with severe disease? And what are your advice to those who are with these risk factors? What are the risk factors? People still do not believe that there is COVID-19. I know you are outside and you might have difficulty hearing me. You are muted, Dr. Jane.
Yeah, can you hear me?
Yes, clear and loud.
Okay. I'm outside in the open air. You can see my background is full of people eating breakfast. We are at a conference. But can you hear me?
Yes, we can hear you.
Okay. So to say, first of all, I want to thank all the extraordinary doctors there standing out and doing what they need to do to help their community. Kudos for you guys. My great respect for you. Regarding what are the risk factors and why people still don't believe in COVID-19, it's something beyond my thinking, because people have their own way of thinking and people have their own role models that they follow. Now, when they see their role model says something or does something that they subscribe to, they choose to do that. And secondly, people have also choices that they want to leave or they don't want to leave. Somebody who wants to leave has a good reason to leave and has a good reason to believe what they want to believe that keeps them alive. For example, I want to get the vaccine. I want to get my mother vaccinated, my family vaccinated, because I want to be alive. Their father is dead. I want to be alive to walk my children to their graduations, to hand them out in their marriage, to see my grandkids. I have a reason to leave. Now, some people have all their different reasons, and they are spreading rumors that this COVID-19 is a hoax. But if you look at people who have died, they died of no chances of their own or no choices of their own. But that doesn't mean that there are people who died with poor choices. COVID-19 is real. It wasn't here until last year it started. And it's real. And for us to come back to life, we need to really adhere to public health common practices, which are very easy and safe. Put on a mask, wear your hand, wash your hands, stay away from infected people, and stay 6 feet apart. Easy, doesn't need money, doesn't need hospitalization, doesn't need insurance, doesn't need anything. And until we think about that greatly, we're going to be in a lot of trouble. In our community, in diaspora and back home, I'm hearing that there is no COVID, but I'm hearing people are dying in Juba. I'm hearing people are dying from other parts of South Sudan. Nobody's even testing them because they don't show up to be tested. They think that this is a stigma. There's no stigma. So you need to show up, you need to get tested, you need to be isolated, you need to take care of your family is bottom line. Now, what do we do about this? Now that vaccines are here, people in diaspora have 100% chances of getting vaccine. Now, at the beginning, a lot of people were running rumors that this is a hoax, they're not going to get the vaccine. Guess what? All those people running their mouth that it is a hoax, all of them have got the vaccine. If you listen to them, you will be dead because they got the vaccine. Every one of them in the US got vaccine. Even those promoting that this was a hoax, they already got their vaccines. So anybody sitting out there think that, oh, Mr. So-and-so sent an email and said this is a hoax, you are lying to yourself. They're going to be alive, you will be dead. Period. They give Alcantara say, Arda Begal, you know, Dunia Bega Jian, Kelna Jara Jara Umahat fi Bahar. Nasenin Jara Umahat one fi Bahar, well, Arda Beg kept his mother and his mother was cooking for him. So it is repeating itself right now. Second, Nasal out of the country here, Basla Nasal fi South Sudan or fi Mahalat Tedin. We understand the World Health Organization is securing some vaccines, but that securing has also a lot of questions. Laano, vaccines are not approved to be used in US and other countries are being taken to South Sudan. Like AstraZeneca, a lot of countries have declined it, including Germany, US, UK, every country, UK still has it. Most of the other European countries have pulled out of it. But they took that to Africa. We don't know if it works for the strains we have there because nobody's testing strains in South Sudan, I believe. In Arizona, we have our new strain of Arizona strain. We have California strain, UK strain, South Africa strain, Brazil strain, but we have Arizona strain also here. So those things are all puzzles to be factored in to understand if the vaccines will work. Now, vaccine we are now having another challenges with Johnson & Johnson because about 8 women have been affected with blood clots. One has died. 2 remain in critical conditions. Some others are still also in the hospital and some are at home now. They have not disclosed the ethnicities of these women. So the risk factors especially for Johnson & Johnson is very great in our community. A lot of our people that have sickle cell anemia, sickle cell trait, and some form of allergies needs to stay away from it. Women that smoke or have a history of using birth control needs to stay away from it. Why do I say this? Johnson & Johnson has the amount of birth control form medication into the vaccine 3 times the normal dose of any vaccine. Johnson & Johnson vaccine is different from Moderna and Pfizer because it was made through the traditional way than these 2 other vaccines were made used from the messenger RNA. This needs to be clearly explained. So if you're a woman, you're smoking, you're using birth control, do not show up for Johnson & Johnson vaccine. The Catholic bishops had put out a statement originally when it was launched out that it has 3 times the amount of birth control, therefore they're not recommending it for the Catholics. If you're older and you don't have those risk factors, you can have it, but right now in the US it is pulled out of market. And I caution Black women because a lot of us do not go to get checked out. You don't know if you have risk factors for clotting or not. You don't know if you have other risk factors that are related to sickle cell anemia trace, and all that stuff. So preventing those things are very, very important. And then if you're in a childbearing age, you also need to think about not getting Johnson and Johnson because of the amount of birth control medication in it.
Thank you, Dr. Jane. I am glad you touched on those vaccines. What are the different vaccines that are being used in the US? You've talked about Johnson & Johnson. What are the mainly approved vaccine in the US?
We have Pfizer vaccine. That's what I got. I got Pfizer. My mom got Pfizer. Most of my family got Pfizer. There is Moderna. My office is going to get Moderna next week. We are going to start vaccinating from my office. I'm getting Moderna and some Pfizer. Johnson & Johnson was approved. The side part of it in the state of Arizona, because of the way the storage works, they took Johnson & Johnson for the people of the lower income because it can be administered in the park and anywhere, and it's only one dose. You don't have to chase after them twice with appointment missing and things like that. But since then has been pulled away. We do not have AstraZeneca used here. AstraZeneca has been approved, but given to Mexico. We have not used AstraZeneca in the US, and it's not going to be used in the US. AstraZeneca was only approved and given to Mexico and Canada. We do not have AstraZeneca. So we have right now 3 vaccines that had emergency authorization use. 2 are in use. Johnson & Johnson is on hold under investigation for the 8 women affected with blood clots. I think there are more, but we don't know. Some people have not reported. And a lot of people are not using the CDC guidelines for reporting. After you receive your vaccine, you're supposed to go onto that site, that's VSafe, and then enter your symptoms. It records you there, and every day it sends you a text message reminding you that you have to enter your symptoms for 2 weeks, 3 weeks, and 4 weeks. So you report your symptoms daily up to 7 days, and then every week. You report your symptoms directly to CDC. And if there is anything, they call you. When my arm swelled for the second vaccine, I reported it. I got a call from CDC. So that's what I know. And if we follow that, we should be good. But South Sudan has to watch out too. I hear that some of the vaccines sent there are expired before even administered.
Thank you, Dr. Jane. You have a private practice and you have been working tirelessly since the beginning of the pandemic until now. In terms of management of COVID-19 cases, what is the best practice in diaspora for the management of mild, moderate, and severe cases that you have treated and worked with?
Can you repeat that question, please?
Management of COVID-19 cases. I know you have worked tirelessly with a number of patients who had either mild symptoms, moderate symptoms, or severe cases in the ICU. What is the
management is really supportive treatment. We have protocols and guidelines to follow. People who have mild symptoms, basically, we instruct them to stay home, isolate, drink plenty of fluids, eat and rest. Avoid NSAIDs. NSAIDs are things like ibuprofen, Aleve, and all those. Avoid those. You can stay home and rest, hydrate, and be good. Check your symptoms, check your temperature every day, check your oxygen status several times a day, and then report if there is any symptoms. That's one. Now, people who have moderate symptoms, which include shortness of breath, these are the people that will need to come to the hospital to be observed for a day or 2, and then sent home when their oxygenation status improves. They do not require any ventilator. They do not require anything more than a simple oxygen mask or a nasal cannula. Those people are monitored for their symptoms. They're monitored for the effect of COVID on their lungs. So we do a daily chest x-ray, we do a daily CT, we monitor their lungs. And those are the people that we put them on some medications. We put them on steroids, which we use dextromethasone. We put them on blood thinners, and then we do supportive treatment. Again, the supportive treatment excludes anything NSAIDs. Now, those with severe respiratory symptoms, those are the people that require ICU beds. Those are people that will likely put them onto high flow oxygen, 55% to 70% high flow oxygen. They can be on high flow oxygen mask versus ventilator. Now, if they do not respond to the high flow oxygen, then we can put them on the ventilator. The high flow oxygen can be administered through other machines like the BiPAP or the CPAP machine, and they can be safely monitored there while they are sedated to preserve the organs, to preserve the body, to vital, so that the body doesn't get tired of using everything and burning things through that fever and all that stuff. But mostly importantly is to make sure that there is the pneumonia associated with the respiratory infection is addressed and it is taken care of. The lungs, the kidneys are monitored daily, and the heart is monitored daily. And that's part of it is why we lay them in prone position, is so that they can drool out and everything, and they can have a little bit of relief from that. So monitor the blood clots, monitor the heart, make sure that there's no fluids building in it, monitor the lungs, make sure that the lung is not completely exhausted. And that's about it. Those all vital organs are the reasons that the people are in ICU. And over time, a lot of them improve, they get out, and some people who are not improving, those are the people that are really unlucky, and those are because most of the times the lungs are damaged, the heart is given up, the kidney is given up. Not so much the liver, but those three items, when they start giving up, it's not a good sign. Of course, we can avoid those by putting on a mask.
Thank you very much, Dr. Jane. What strategies have been put in place to control the spread of COVID-19 in diaspora? You can base your answer on the cases in the US. What has worked? What has not? And what do you think South Sudan can emulate?
Well, US is a very big country, and we have all states have their own rules that they follow, their public health policies that they follow. Though we all follow CDC, the interpretation of the CDC and the scales of where the states are differ. So, for example, in our state of Arizona, the governor went in March and said, hey, COVID is gone, everything is open, right, wide open. Our positivity percentage was around hovering 5. Guess what, where we are now? 8. It is going up every day because the bars are open, the clubs are open, people are eating, dancing, restaurants are all open. People are doing what they want. The governor took away the mandate for the mask, but businesses still require masks. So in the clinic, I have a mask requirement on the door. If no mask, no service. So people are still using the mask whenever they want to. If you go golfing, then you don't need a mask. You're swimming, you don't need a mask. But other places you do. So public health measures from state to state is really what is helping people and what has really worked. In addition to the effort to vaccinate every adult, the effort to vaccinate every adult is what is working. We're here at the conference. All of us are vaccinated, except for maybe 2 or 3 people who are very sensitive to that. But in hundreds of us are here, all vaccinated healthcare professionals, doctors, nurse practitioners, physician assistants, and we have had no incidents. But so Juba or South Sudan can do exactly what is suitable for them. And what is suitable for them is the cheapest method, which is public health measures. Put on a mask, don it on. It has to cover your entire mouth and nose. Do not leave anything open. All of it has to be covered. But if you don't cover all of it, it is not useful. That is going to be the best, the cheapest, the easiest, the safest. And then overcrowding. Yeah, Jama, I don't know what I can say. You know, nas lisa gijama fi iris, nas gijama fi hajat. You know, we just saw the funeral of the late bishop.
Yeah.
And the overcrowding is something else that needs to be discussed in Juba. All those people that were crowding there, they need to start checking themselves and asking themselves serious questions. That after you have been there crowding with those people, you came home, did you isolate? Did you sit away from the family? Are you going to bring that infection home to kill your family? Or what are you thinking about it? Yes, it was good to be there, but after that, what measures are you taking? So I think the people of South Sudan are capable. They see what they see. They can do what they need to do, and they can prevent what they can prevent.
Dr. Jane, what is your
conclusion
and recommendation, if you have any more to add?
No, I don't think I have anything to add. It is time to go back to the conference place.
Thank you very much for giving us the time of your busy schedule. We appreciate your knowledge all the time, and we wish you all the best with your conference. Thank you for joining us.
Thank you. I appreciate it.
Thank you.
I'm going back in there, and I will be on mute in case of anything. Okay. But I will keep up listening, but I'll be on mute.
Thank you very much, Dr. Jane. You have a great day during the conference.
So you see there, we have people are starting now.
Thank you. Dr. Alice Igali Ladu, what are the current statistics of COVID-19 pandemic in South Sudan? What is the current trend, and what may be the reasons for this?
Good afternoon. Thank you, Dr. Akot. So the current statistics for COVID-19 pandemic in South Sudan as of yesterday, the 16th of April, we have a cumulative number of confirmed cases at 10,432, with 0 admissions and 123 active cases as of yesterday. So all these cases, the 10,000, majority of the cases, over 76%, are coming from Juba, from Central Equatoria State. The rest are from the other states. We have cumulative number of deaths at 114 deaths reported as of yesterday, which make our CFR at 1.09%. We have, as of yesterday, 15,623 contacts followed, with over 14,000 of them have already completed their 14 days follow-up. And 91% of all these cases reported are asymptomatic, which makes only 9% of the cases asymptomatic. And majority of the cases are male. Over 61% of all the cases reported are male, and the female is around only 23%. So most of these cases were confirmed in travelers. This is the highest number of people who have been testing. Most of them are travelers, followed by the contact tracing team when they collect samples for testing. And then the alerts is the third category in the testing. So our positivity rate in South Sudan have come down to around 3.5% as of last week, compared to 22% that was in week 7, our epidemiological week, that was around 7 to 6 weeks ago. As I said, the positivity rate have gone down. So when we look at the trends, the trend of the cases, it shows that there is a reduction on the number of the positive case in the last 6 to 8 weeks. So we are attributing this maybe to the lockdown, the partial lockdown that have been imposed by the government, and as my colleague Dr. Sandra have said, which was released 3 days ago. This is why we attributed the reduction in the positivity rate, and also maybe because there is somehow slight improvement in the adherence to the public health measures. As you go to the functions, you can find almost half or less than half of the people are putting on their mask. This is what I have. Thank you. Dr. Kot, you are muted.
Thank you, Dr. Alice. What are some of the factors driving the COVID-19 pandemic in South Sudan, and why are some of the possible solutions and strategies in place to combat the transmission?
Thank you. For me, I can divide the factors driving the COVID-19 pandemic in South Sudan to 3. Number 1 may be the individual factors, where we have lack of adherence to the COVID-19 public health measures, like wearing masks, hand washing, social distancing. As my colleagues have said, when you go to the outside, you can see that people are still practicing the occasion. Normally, there are funerals, prayers happening, exception for weddings. This may be one of the factors at the individual level. Then at the community level, we can see that although the masks have been distributed, but most of our people in South Sudan cannot afford masks. And although we have given this Kitenge use mask, but we are not sure if people are really washing it every day. So people cannot afford masks, and also there is challenges with social distancing. In COVID, we are advising that people should stay 2 meters apart. And most of our cases, as I said, only 9% are asymptomatic. The rest are asymptomatic, so they are treated at home. We know in South Sudan, we have this issue of houses where average we can have 10 to 15 people in the same house. So although people are staying at home, as we said, home treatment, but we can find that people cannot afford also to have separate rooms in the houses. People cannot afford to have special or private bathrooms. Also, at the community level, we can have the issue of lockdown. As a country, we cannot afford to do total lockdown because most of the goods, the food items, for example, are coming from Uganda and Kenya. If we do complete lockdown, people will not get what to eat. And also because of the low income rate, people are depending on day-to-day income. Like our mothers, our sisters who are selling teas, those who are working in the markets. If we do complete lockdown, also this will not help, it will not support people. And at the system level, we have lack of resources, not enough resources for mandatory isolation. Like the government cannot do mandatory isolation in some places because we don't have this luxury of people having private rooms in the houses, so they can just go to the mandatory isolation. So do we have lack of resources? I think this has been discussed earlier when we confirmed the cases in South Sudan, but this was not possible. People were thinking of using schools, but this was not possible. So this is how I look at it at the individual, at the community level. So some solutions that we can think about is mask distribution of regular distribution of masks, not only once, but we have to make sure that we have regular distribution of masks, and social distancing. although the lockdown have been raised, but we have also to make sure that there is social distance in the occasions. People are putting masks, people are washing their hands. And another thing, the home visitation, like for example, when people are confirmed positive, because most of the people are not testing, people just say, I think I have COVID, and they're staying at home. Also, we need to do a lot of risk communication and community engagement, community education to people on how to prevent themselves and how to control the COVID. And also, generally adherence to public health measures and public health measures by the government, by the institutions. Yeah, we have a lot of challenges in South Sudan, but I think it's we can just solve it one by one. Thank you.
Thank you very much, Dr. Alice. You had mentioned earlier that the highest number of cases were mainly in Juba. What are some of the reasons for that, and what strategies are being put in place to mitigate this? And are we testing more in the other regions? Because COVID-19 symptoms are almost the same like the malaria symptoms. Are we doing more testing in the other areas? Because when I was in Juba, there were only 2 or 3 areas for testing for COVID-19. What about the other states?
Thank you, Dr. Akwot. Yes, most of the cases were reported from Juba. As we know, Juba is the capital of South Sudan with a very dense population. There are many people staying in Juba. This may be also one of the reasons. Also, we have the Juba International Airport in Juba, where all people land in Juba first before they go to the other states. Also from Nimole, most of the people coming from Nimole, they come to Juba first before they go to the other states. Another factor also why we have increased number of cases in Juba is because most of the testing sites are in Juba. If it is the government site, or now we have the private testing facilities, we have more than 3 functioning, I think. All of them are in Juba. So at the state, yes, we have a low number of testing or reduced number of testing sites in the state. Now we have the sentinel surveillance, and we have over 14 sites. 3 of them are in Juba. This was established before the COVID-19, and now we have decentralized them to the state level, where we have at least one site at the capital. And this is also one of the issues. It's only one site in the state level, in the capital, and we know that we have over 80 counties in South Sudan. So imagine how can these people at the peripheral part of the state, like the counties, the bomas, the villages, to reach the state level. Yes, as of now, I think we have 27 sites in the states, but also compared to Juba, this number of testing sites is very, very, very low. And also we have, out of 80 counties, only 35 counties have reported cases of COVID. Also, this also because of the issue of the testing. Yes, we have a mechanism which is in place for the last few years to bring samples from the states to Juba. But also there is the issue of delayment. When the samples are collected, by the time it reaches Juba, it's 3 to 4 days by the time it's testing. For the result to go back to the Juba, already we have lost the case. And if the case have listed contacts, when you come to the contacts after 1 week that this case have listed you as a contact, we want to collect your sample, of course they will not accept, because by now the case is mostly okay, is asymptomatic. So those are some of the challenges that we are having, but to combat it, I think we need to increase the number of the testing facilities at the state level and at the county level. I think we have partners who can also support that, and we have the private health, private testing facilities. Also, if they can be encouraged to go to the state to practice this testing at the state level. Thank you.
Thank you very much, Dr. Alice Igali Ladu. for explaining the challenges that are facing our country. Now, I would like to ask Dr. Anne Ito, Dr. Anne Pitia Lamule, why are the number of COVID-19 spiking globally despite measures being taken by certain countries, including the lockdown? That answer has been answered, I believe. So I would like you to explain the presentation of COVID-19 in children, with you being a pediatrician.
Okay, thank you so much for that question. I think, as you've said, then about the numbers spiking around the world, Dr. Jane has actually focused on some of the reasons, and my colleagues have also focused on some of the reasons. And what's important to note is that the situation is not the same worldwide. There are places where actually the cases are going down, like the Americans in Africa. However, there are places where the percentage of rise is even up to 29%, like in the Western Pacific, in Papua New Guinea, and in the Philippines. And the general trend is about 8% rise in cases worldwide. And apart from the fact that people are not adhering to the public health measures, the simple public health measures that my colleagues have mentioned, the other issues that actually led to this exponential rise in cases that my colleagues have not mentioned is the appearance of new variants of the virus. So generally, microorganisms, and whether they're disease causing or not, have developed adaptation over time to learn to change their appearance, to learn to change their ability to infect, so that they are able to replicate more effectively. And the coronavirus is not different, in the sense that it is able to mutate, it is able to change what we refer to as antigens, so that the various variants of the virus are going all over the place. And I think Dr. Jane mentioned that they even have an Arizona variant of the virus. And this is important because as the virus changes, then it means that it might develop the ability to easily infect people. It might become more contagious, and it can become more virulent, in the sense that it's able to replicate more effectively in the human body. And this poses a challenge to the control of the pandemic, because if our immune systems are unable to recognize these new variants, then it puts us at a situation where there's a risk that people will now start presenting with more severe disease. There'll be more cases, and the rise will continue. And therefore, the coronavirus remains a real threat because of this constant, the ability to actually mutate and evade the immune system, which is basically the part of our bodies that fight off infections. So that's simply what I would like to say about that in terms of the cases raising. Now, when it comes to children, sorry, yes, Dr.
Could you elaborate more on the different type of variants? Because we have heard of different countries having different variants. Could you elaborate on that, since you touched on it?
So I won't go into specifics, but what happens when a virus mutates is that what constitutes the virus, what we call the antigens, which are what our immune systems are able to recognize, may change. So different viruses have different antigens, and there are specific antigens that can change, and there are specific antigens that cannot change. So when I talk about different variants, it means that some of those antigens have changed to the extent that they're not recognizable as the previous strains that were circulating when the pandemic initially began. So as surveillance continues, and as the virus is assessed and examined in various labs around the world, then they have noted that there have been some changes in the initial strain that was first identified in Wuhan, China. And these changes do not necessarily give the virus the opportunity to infect more people. It depends on what kind of change has gone on. So some changes actually weaken the strain, and some changes make it actually more contagious and more infectious. So in terms of the details, it's about changing the appearance of the virus and changing its infectiousness so that it's able to replicate more effectively if it can, and it's able to evade the immune system and cause more severe disease. But that does not always happen, but the possibility of it happening is there.
Thank you, Dr. Anne. To the layman people, we have heard of the UK variant, the South African variant, the Brazil variant, and also even in Arizona, there are different variants that are happening in different parts of the world. As a pediatrician, what are the complications that we have seen that kids present with
So when
COVID-19?
it comes to children, I think the three things that we need to think about and we need to put in our minds is that children do get the infection, and children are also able to spread the disease. And this is something that we always have to keep in mind. Now, despite that, what has been noted over time is that children have not presented with very severe disease. Most children present with very mild symptoms like cough, fever, some body aches, general symptoms that can happen when you get a common cold. However, despite that, the fact that most children present with mild symptoms, it has been noted that there are specific risk factors associated with severe disease. So children who are obese, children who have underlying chronic conditions like diabetes, chest conditions, heart conditions, they are more at risk for developing severe illness, although most children actually have mild symptoms. Now, a specific syndrome has been identified recently called the multisystem inflammatory syndrome in children. And this, basically the children present with severe illness and fever and what we refer to as multiple organ involvement, meaning 2 or more organs are involved, either the kidneys, the cardiovascular system, which is where our blood goes throughout our whole body, including the heart, the respiratory system, the system we use to breathe. So multiple organs have been affected. And it is similar to other disease conditions that have been seen in children, including something we call toxic shock syndrome and Kawasaki's disease. So it's been identified mostly in the Europe, in America, Italy, UK, and it's a new entity that people had not come across before. However, most of these children have either a history of exposure to a COVID-19 case 4 weeks prior to the development of this syndrome, or they are actually COVID positive. So this is something that actually puts a number of children at risk. And it's something that pediatricians have to keep in mind and look out for, because when this happens, then these children need critical care and they need to be admitted in the ICU and managed there, because sometimes their organs actually have to be supported with the supportive care that Dr. Jane talked about, with medicines that reduce that overreactivity of the immune system to the COVID virus. And what has been postulated is that in these children seem to have some sort of genetic predisposition to overreact to this virus. And the immune system goes into a dysregulation, which ends up having a lot of what we call cytokines, things that fight infection, that go on to damage multiple organs. And that's why these children present with severe disease. Of course, as time continues, more and more information is being unearthed, and all the details about this disease are not yet known, but at least some protocols have been put in place to sort of manage it for those children who actually present with that disease. But it's important to know that, yes, children do get infected. Yes, children mostly get mild disease, but the possibility of severe illness is there. And if you notice that a child is severely ill, if you notice that they are either having seizures or seem to be too drowsy, are unable to feed, and have severe difficulty in breathing or any degree of difficulty in breathing, then you need to take them straight to the hospital, because that child might actually need critical care services, which involve being admitted and getting drugs within a critical care facility.
Thank you, Dr. Anne. للناسنا دكتور آن بتقول إنه المرض بتاع كوفيد في عيال دائما ما بكون خطر، لكن في بعض الأحيان عيال تانيين بقدر يكون تعبان شديد، فلو جانا عنده أعراض مثلا وجع حلق ولا جسم توقع واجع ولا عنده ضيق في التنفس، وديه للدكتور تو عشان كده عينه، لأنه المرض ده ممكن يمسك أعضاء كتير في جسم تاجنا وممكن يكون خطر، وجانا ذاته ممكن يموتوا. Dr. Anne, you have mentioned that why are children forced to keep away from school due to pandemic in many countries, despite children not being affected as compared to adults since they have mild symptoms? Should South Sudan open schools, and what precautions should they put in place, if any?
So when it comes to the closure of schools and children being kept away from education facilities, the reasoning behind this at the beginning of the pandemic was that not much was known about this disease in the beginning, or the way it spread, or the way it was going to affect particular individuals in the community. So no one really knew how it would affect children. And to prevent the spread, then restriction measures and lockdown measures and even closure of schools was put into play to prevent the spread of this disease. However, with time, some countries have continued with the lockdown and the closure of schools, but some countries have opened schools, and there are actually even other countries who did not even go that route. They allowed children to continue learning. Now, despite that, what needs to be taken into account is this, when we're looking at the closure of schools, whether to do it or not to do it. Number one, schools are crowded settings, especially within our setting in low income and middle income countries. We have schools that are overflowing with children and the facilities are quite limited. So the crowding is an issue because, as we've said, my other colleagues have said that social distancing is a very important part of control of this virus. And if we're unable to do that in schools, then it becomes a problem because we have this huge number of children also interacting with adults who are their teachers, who might also be at risk. And the possibility of them transmitting the virus among themselves and to these adults is also there. Number two, especially children of a younger age are generally, just because of their behavior, are unable to strictly adhere to some of these public health measures that we are talking about, like the wearing of masks. You'll find that for most of the patients who come to me, they tell me, I get to the school and I find the mask is gone, or it's on the chin, or they have shared it with their friends, exchanging masks because of those cartoons that are on some of these really nicer masks for children. And they're busy touching each other, playing, blowing their noses into their hands and just, well, basically just spreading the virus. And this happens with other respiratory illnesses. And because of this, then, of course, you tend to think that the younger generation might not be able to adhere to some of these public health measures that we are saying are the simplest ways to prevent the spread of this virus. Now, the other thing is that at the moment, Dr. Jane has talked a bit about the vaccines. Most of these vaccines have only been assessed in people who are above 16 or above 18 years of age. So it's not including the children who are much younger. And therefore, as even despite the fact that studies are currently ongoing to see whether the children can get the vaccines, this is not the reality yet. So they do not have the benefit of protection from vaccines at the moment. And therefore, some countries decided to close schools and some countries decided, well, our pandemic hasn't reached the state where we should close schools, and they continued with schools. Now, for the ones who decided to open and for the ones who decided not to close schools, some of the measures they've put in place are, one, they have ensured that the students are learning in very airy, well-ventilated rooms. They have ensured that there is some sort of social distancing that happens. So they either stagger the classes, or they create schedules where some children come one day and other children come another day, or some come in the morning, some come in the evening. They've been able to separate the desks for the children and ensure that there's provision of masks, and children and also the teachers are wearing the masks. They have also ensured daily disinfection of the schools, both the schools and the surfaces, and they have cancelled events that might require too many people in one place, like sports and crowding in games and events. And they have also ensured that there is a process for identifying those who are unwell and for referring them to the correct health facilities, and to ensure that they are tested and go into quarantine for a duration, a number of days. And then when they come back, they're tested again before they're let into school. Now, unfortunately, in our setting, it might be difficult to actually set all this in play due to lack of resources, number one, and due to the fact that we're basically overwhelmed in terms of the numbers in our schools. And only when you can ensure that this can be put in place, then it becomes difficult to blanket recommend an opening of schools. So this is a decision that has to be made on country basis. So you have to look at the pandemic, as Dr. Sandra was saying. You have to look at what the numbers are in your country, how the spread is, and what the case fatality rate is. How is it affecting the children? And then decide, is your pandemic at a level where it's at a peak or it's exponentially increasing, and whether it's the right thing to open schools during that kind of state. So you have to look into that. However, for those who decide to close schools, then you also have to decide what happens to the education of your children. Are you going to give alternatives? So some of the things that have been suggested are online learning, which we know for sure in our country is not accessible to everyone. Some of the things that have been suggested are radios, but not every home has a radio. TV, not every home have access to electricity. In fact, the other day, the power company had sent out a press statement that there will not be electricity available in particular areas in Juba, the capital city. Now, imagine if we have that kind of scenario in our capital city, then what happens to the rest of the country who basically have no access to infrastructure? How do you expect them to access the television, to access the radio when there is no electricity? Some of the things that have been suggested are homeschooling, where teachers go to homes, but how many people are able to afford that? And we also placing those particular homes at risk, because these individuals that come into those homes can also spread that disease. So for South Sudan, I would say that there is no blanket recommendation for any country, and each situation has to be assessed on one-to-one basis in terms of what the situation is on the ground, what the reality is on the ground in that country, and whether they're able to put into place these measures that we have mentioned that will prevent the spread of disease among the children who show up in the school facilities, or if we are able to offer alternatives so that the education of our children can continue. But what we need to keep in mind is that we cannot continue restricting education forever. So hopefully with the advent of the vaccine, then more people are able to have protection, there's less transmission of the disease, and we are able to actually go back to whether it's normal or semi-normal life, and our children are also able to get an education. But it has to be on a case-by-case basis, depending on the country involved.
Thank you very much, Dr. Anne, for that elaborate answer. Yes, staying at home, you look at all the risk. Do I let my child stay at home and study online? For those of us who are in the West, it was an option. But even that option, I can tell you as a mother, it was very challenging. I had to send my son to school. My oldest daughter is still continuing from home. My youngest, she decided, Mama, this is too much for me. I cannot do it at home. So I sent 2 of my other kids back to school. And a lot of children are getting in touch with people, with other students who are also positive with COVID-19. So a lot of kids have been sent home in quarantine to quarantine for that particular period and then come back. So there are a lot of challenges. Is South Sudan geared for online schooling? No, we don't have the means, we don't have the computers, we don't have the space for people to study because our homes are so congested. We have to look at it. Do we need to live or do we need to die? So we look at both ends, and do we need to educate our children? So all these things are important. Each country is different, and each policy will be made accordingly. Dr. Sandra, the vaccine has reached South Sudan, and there were a number of challenges. What is the rollout? I will combine a number of questions together. Who are the first people to get the vaccine? We had a period of almost 7 days without the vaccine being started when it first was introduced. What are the strategies put for the rollout? Who are the people to get it? Are they frontline workers or just the politicians, as we have been seeing in the TV? And what are the challenges that are being faced? What is being done to educate people who are hesitant to take the vaccine? Over to you, Dr. Sandra.
Thank you, Dr. Kot. Indeed, everywhere around the world, people are talking about COVID vaccines. We have so many COVID vaccines right now, and there's a lot of confusion onto which one is the best for an individual. Which one should I take? Which one should I not take? And also, it's the development of the COVID vaccine actually broke a record. It is one of the fastest vaccines that were developed ever. I mean, when we look into history, we see that was it the mumps vaccine took 4 years to develop, which entered history as the fastest vaccine to be developed ever. And here we're looking at the COVID vaccine, which took less than a year, or roughly a year, to be developed, to be manufactured, to be distributed, and to actually be given to individuals. So South Sudan being a member of the WHO as well, and also being a low to middle income country, it was given an allocation of vaccines through what they call the COVAX facility. So the COVAX facility is WHO, UNICEF, Gavi, CEPI, and I believe 1 or 2 other institutions as well. And the aim of the COVAX facility is to ensure that they give around 2 billion doses of vaccines to low and middle income countries, I believe by the end of 2022. So South Sudan, of course, automatically entered into that plan, and the development of the national vaccination deployment plan started since September, October last year, and by early February this year, that plan was finalized, and of course, it takes into consideration the country context, etc. But I think the one limiting factor we have in this plan is that as a country, we don't have the option of choosing which vaccine we want to have or we want to give individuals, and we don't have the option of having 2, 3, 4, or 5 vaccine candidates or 4 or 5 vaccines to give our people. The type of vaccine that is distributed through the COVAX facility is what is known as the Covishield, which is the AstraZeneca vaccine manufactured through the Serum Institute of India. So we all know that there's a bit of chaos going on with regards to the AstraZeneca vaccine nowadays and the Johnson & Johnson vaccine. But going back to AstraZeneca and the few reports that were circulated regarding blood clots, etc., it still has a very high efficacy rate, over 90%, anywhere between 77 to 90%. So it has a very high efficacy rate, maybe slightly less than Pfizer, but equally so as Moderna, etc. So when you look at the vaccine per se, it is a good vaccine. It gives a strong immune effect. it's different from the Pfizer vaccine in that it uses another virus as a vector, which is a harmful virus, but so sometimes it triggers a strong immune reaction. But let's go back to the the South Sudan National Vaccination and Deployment Plan. So the initial aim is that South Sudan has is to vaccinate 40% of its population. And given that we are at a population of 12 million, the hope is to vaccinate 4.8 million people against COVID-19 by the end of 2022. So through the COVAX facility, South Sudan will gain vaccine doses enough to vaccinate 20% of the population, which is about just around 2.5 million people. So this is the vaccine. This is the number of people who will be able to vaccinate with 2 doses with support from the COVAX facility. And the vaccination has started. I believe it started about 10 days ago. And so far, it only started in Juba County. But the vaccination plan does include different, all the different locations across the country. It considers all the counties and the Payams, etc. But of course, Juba being the main hub or the biggest city we have in the country, the vaccination process is rolling out from Juba. And there's information that currently they're working on the microplan for Western Bahr Ghazal, Upper Nile, I believe, as well. So slowly, hopefully not too slow, we are seeing this vaccination being rolled out from the central level to the states. I think the main challenges we've been having is the issue of funding. So we do have basic infrastructure that facilitates the vaccine rollout, such as the cold chain, such as the healthcare workers. Trainings have been conducted in Juba. Training of trainers have been conducted as well. All the necessary documents and cards and charts, etc., have been printed and sent to different locations. So we currently have 3 vaccination sites in Juba. We have Juba Teaching Hospital, we have the Juba Police Hospital, and we have Juba Military Hospital. So from the 20% of the population, this translates to 8,064,000 doses. Unfortunately, the COVAX facility told the country that they will deliver, I believe, 736,000 doses only. And currently in country, we have received 132,000 doses. So these doses, if we are to secure another lot of vaccine, it means we will vaccinate 132,000 people now. Otherwise, we'll have to use that vaccine to vaccinate just over 60,000 people and maintain the remaining portion for the second dose to ensure that everyone gets 2 shots. So from the 20% to be vaccinated, the amount that we have received or the initial target of people to be vaccinated are considered among the 3%, which is the 132,000 doses we received. And this selection of who should be vaccinated first is not just out of the blue. It's not, oh, I want to get vaccinated, so pick me. It's been done in accordance to the WHO SAGE guiding principles, which is a tool that facilitates prioritization of vaccination and prioritization of categories and groups based on, it's a tool that is used to help countries select priority groups based on, because of their low and middle income as well. So the SAGE guiding principles were used, and so far we have the vaccination will be rolled out in 2 phases. So we have phase 1 and phase 2, and hopefully there should be a phase 3, but phase 3 can only be assured and secured if we have enough vaccine doses to vaccinate the 40% of the remaining of the 40% of the population. So in the phase 1, we have phase 1A and 1B. In phase 1A, we have the healthcare workers and frontline workers. So healthcare workers is everyone working in a healthcare facility, being that person a doctor, a nurse, a cleaner, a lab technician, a janitor, whoever is working in a healthcare facility, whoever is taking care of sick people, seeing patients. Just you being present in a healthcare facility, you are designated as a healthcare worker. And then we have the other frontline workers, such as the community community healthcare workers and community mobilizers. We have BOMA health promoters. So all these groups who are at a higher risk of being exposed to a higher number of population are considered in the first category. So that is category 1A, the healthcare worker and frontline workers, and then category 1B, which should be which have already also started vaccinating, is the elderly people, and these are people above 65 years of age. So over the past week or so, we have seen individuals from these two categories being vaccinated at the 3 vaccination sites in Juba town. In the phase 2, which is also part of the 20% to be vaccinated under the COVAX facility, we have people living with comorbidities such as those with asthma, tuberculosis, diabetes, high blood pressure, etc. We have people who are immunocompromised, such as people living with HIV/AIDS. We have high-risk populations, such as those living in refugee camps, IDP camps, etc. We have also, I believe, school teachers have also been included in that. We have these categories that are listed in phase 1 and phase 2. More or less, what we see here is the vulnerable population, those who are at high risk of being exposed to a large number of people. So hopefully, we've only received now 132,000 doses, and I saw a rumor circulate in some social media platforms yesterday that these 122,000 doses are actually expired, and that's not true. These doses have an expiration date, I believe, until mid-July. So we still have time to use those doses. We still have time to roll out the vaccination to the different counties. But the only challenge we're facing is the issue of funding, because it's not easy to just put vaccines on an airplane and send it to the field. It also has a very heavy financial and logistical aspect. Logistics is actually what is guiding this right now, because healthcare workers are ready. The country has decided to use the existing vaccination structure that is being rolled out under the Health Pool Fund, etc. So we do have vaccination points across the country, because we have the regular and routine immunization that occurs frequently. So the country is going to use that and use the same nurses, healthcare workers to administer the vaccine to individuals. So basically, we as a country, we have AstraZeneca. We have 132,000 doses. Vaccination has started. We do see in social media platforms that senior level politicians are being vaccinated. And it's not, I believe it's not in favor that, oh, they're senior level people, so they should get vaccinated. But some of it is because we also need we need to see the political will, and we need to see the political leadership to erase some of the hesitancy. There's a very large hesitancy with getting the vaccine. When in February and March last year, everyone was asking about, oh, stop talking about Corona, just get us the vaccine. And now nobody wants to hear about the vaccine. It's very paradoxical how people really wanted the vaccine, and now that the vaccine is here, nobody wants it at all. Political will and political leadership is very important here, and it's good that we've seen some of these political leaders getting vaccinated and making public them getting their shots. I believe some of them also fall in the category of above 65. So if you are above 65, you need to go get your vaccine shot. And the main objective is to ensure that we have enough vaccine quantities for the 40%, or right now we're starting with the 20% population. The vaccination plan is to ensure that we have enough quantities, and that the prioritized people, or those who deserve to get the vaccine, actually do get it. And of course, we also need to monitor any adverse effects. So it's not that South Sudan is not keeping an eye on any of these adverse effects that we've heard about in the news. But when we look at AstraZeneca, for example, millions of people got the shot, and we've had reports of only 6 people develop or report these blood clot complications. So when you convert that to a percentage, the risk of you developing a clot is very, very low. I've seen other countries recommend that they will only use the vaccine in certain age groups, which is fine. I mean, we've seen from our colleagues here and from other community members that those who are over 55 and got the vaccine didn't really complain of like fever or pain in the site of injection or any other effects. But we've seen people of younger age groups actually say that, yeah, you know, I got a very high fever, I got fatigue, some people have developed cough. So yeah, we've seen that the younger age groups do complain of side effects, but these are normal side effects. It's expected with whatever vaccine you take. And also there's a difference between a side effect and a serious adverse effect. So we really hope that we don't see any blood clots developing in anyone so far. I mean, we do have a very small number of doses right now, and I believe that with the small number of doses, the chances of seeing anyone developing a complication like the cerebral venous sinus thrombosis is very, very, very low. So yes, we have partners engaging with the community to increase the demand generation, to erase the vaccine hesitancy, etc. But maybe I'll share with you some figures as of, let me say as of yesterday, which is the number of people who have been vaccinated in South Sudan so far. So far, only 2,089 people received the vaccine in country. So we have thousands of doses, but only 2,089 people received the doses. And from the 2,089, 929 are healthcare workers, and the others are in other groups, mostly other different high-risk groups. And we have a small portion of those who are above 65. We also have a mixture of healthcare workers who are above 65 as well. But yeah, when we look at 2,000 and the number of vaccine doses we have, we've only used 1.6% of the vaccine doses that we have. And we really need to ensure that we do expand our vaccination coverage, our geographical coverage. And it's been difficult for healthcare workers also because when we see then the percentage of healthcare workers who are supposed to be vaccinated, only 24% have in Juba have received the vaccine. Maybe perhaps some healthcare workers in primary healthcare units, for example, are finding it difficult to reach these vaccination centers that are stationary, are not mobile. So I know we believe that the vaccination working group is engaging with the ministry and other partners to ensure that the vaccination process is more mobile and more user-friendly to individuals, and that the vaccine reaches people where they are rather than the people looking for the vaccine. So basically, this is in summary the current vaccination rollout in South Sudan. Over to you.
Thank you very much, Dr. Sandra. I will try to say what you said regarding the vaccine in Arabic. تطعيم وصل في جوبا. أنا بحاول أترجم كلام اللي قالوا دكتورة ساندرا. تطعيم وصل في جوبا يا أخوانا. لما التطعيم كان ما في، ناس كان قاعدين يقولوا جيبوا لنا تطعيم، جيبوا. في أنواع 3 في دول هسه، في فايزر، في موديرنا، في أسترازينيكا يا هسه وصل في السودان، وفي برضه جونسون اند جونسون، وهسه ده وقف شوية. يا جماعة في إشاعة كتير كتالة زي هسه ده ناس برقي ونسوا قال تطعيم اللي جابوه في جوبا ده مدته انتهى، مدة بتاعه ما انتهى. دكتور ساندرا هسه وضحوا لنا إنه مدة بتاعه بينتهي لغاية شهر 7. إحنا هسه في شهر 4 يوم 17. فيا جماعة كنا ما لفوا بتلفون دلاجين، كنا شيلوا medical facts، يعني حاجات الصح ونبغري للناس. مرة ده الاسم تو كوفيد ده قتلوا ناس. كنا نروح في محلات ال3 الجبال وريدة، مستشفى جوبا التعليمي، مستشفى بتاعت عسكري اللي هو military hospital بتاع الجيش، ومستشفى بتاعت البوليس. دي 3 أماكن القاعدين يودوا فوق التطعيم ده. ناس كافوا أخذوا التطعيم ده. أنا اللي قدامي تكون ده أنا أخذت التطعيم، أخذت 2، أخذت فايزر. لما أنا أخذت الأول ما حصل لي أي حاجة، حتى وجع اليدين ده ما في. لما انا اخذت الثاني انا قاعد نحس جسمي زي تقول في برد. دي او حاجات اللي كان فيه. في محل شغل مرتين انا جا وانا جم ناس اللي عندهم كوفيد 19 وانا كان ما بعرف، لكن لانه انا كان قد لبس كمامه التطعيم ده، انا بفتكر انه التطعيم ده ساعد عشان المرض ده ما بيجانا. فيا اخواننا امشوا. ناس الاول ناس تاني كيم قال اوه كلام ده جابوه للسياسيين، ما للسياسيين. سياسيين قا اخذوا التطعيم ده عشان كده مروري لي تكون قال يا جماعه تعال تكون انك شيلوا فاكسين ده لانه فاكسين ده كويس كي تكون شيله. حاجه ده في العالم كله. انت بعين رئيس امريكا لما اخذ جاء في التلفزيون اخذ تطعيم، نفس الحاجه رئيس الناس الفكير والناس رياض مشهر وباقي ناس الثانيين ده. دكاتره لنا كمان في جوبا هم اخذوا. ناس في مجال الطب ده دور تكون كده معلموا الناس عشان كده الناس روحوا اخذوا فاكسين. Dr. Sandra, I have a question for you regarding the facilities in Juba that are used for COVID-19 management. A lot of people are saying, kan tara fi center ta Juba da, kalas ya wata gira mutu. Kede warlena center da amru le shino, le nas giro hinak. Unas tanina gigeni lagayt akir zaman, yala bro hinak, yala karum muro mutu, yala mo kengal inna mashena hinak yaw. Zolda wada hinak mat. Ana indi wada ammi kan fi center da abuna وقبل كده نعمل له انترفيو وعايش. ففي ناس بدخلوا وبتالا وفي ناس تانيين بموتوا زي باقي ناس تانيين الموتوا في حالهم. So please explain that part to us. What are the facilities available and what are the services provided at these areas? And you can conclude from there.
Okay, thank you, Dr. Okot. So we have several isolation facilities across the country. We have, I believe, between 17 to 18 healthcare facilities that have capacity to isolate COVID-19 patients. But the main one, which is of course more well prepared and more advanced, is what we have in Juba, and it's called the Dr. John Garang Infectious Disease Unit. So the IDU was developed in efforts for Ebola preparedness about 2 years ago, in collaboration between WHO and the Ministry of Health, etc. So this isolation unit was initially set as an infectious disease unit to harbor and manage any infectious disease, excuse me, to manage any infectious disease of any sort that surfaces. So when, of course, we didn't get any Ebola case in the country, so no Ebola patient or suspect was admitted there. But when COVID came, COVID is another infectious disease. So the facility was just adapted slightly to be able to manage COVID patients. For example, they introduced oxygen concentrators, oxygen cylinders. They introduced doctors and critical care specialists who specialize in respiratory critical care, etc. So that facility is well prepared to accommodate and to manage moderate to severe to critical cases. We still don't have ICU capacity in South Sudan, which is the intensive care unit, which is where you have people, individuals attached to a mechanical ventilator, and then they're sedated. Of course, we don't have ICU capacity yet, but we do have ventilators. So if there is any patient who is very critical and that patient needs to be ventilated, that is available in country, and it's available at the infectious disease unit, which is what people call the COVID quarantina or whatever, and they're actually afraid to go to. So we know that almost 200 people, if not more, have received care there, and almost 80% or 90, almost over 80% of them were actually discharged and recovered. And of course, when a person is very, very sick and that person reaches the stage that they need critical care and they're admitted and they're ventilated or they're receiving oxygen, especially with COVID, and especially if you have other comorbidities and if you've come very late and you succumb to the illness, then there's not much that can actually be done. So we do know that a few people have passed away whilst their admission at the infectious disease unit, but we also have over 150 of them, who are admitted at that facility and who received care and who were discharged and they went back home. So I also know that there is a video that is supposed, this video is supposed to be out since last week, I believe, and it's to create orientation or awareness on that specific facility. So that video has the partner who is managing the facility and Ministry of Health, taking people through the different rooms and areas in the health facility, just to show people. I think it also shows pictures of people who are sick and who are currently being admitted, just to show people that this is the reality of what's happening inside here. So I do urge that if you do have COVID symptoms and you have difficulty breathing, call the hotline, the 6666, and they will assure that they send the correct team to come and see you. And if you do need to be taken to a healthcare facility, if you're in Juba, you will most likely be taken to the IDU, the infectious disease unit. And it's not a place where people are abandoned and people are neglected. It's not a place where they take you to die. It's a place where they actually take care of you. They give you the necessary treatment, the necessary support that you need until you recover and get better. And I also want to let people know that we don't have a treatment for COVID-19. We don't have a cure. We don't have a tablet or an injection that you take and you recover. What's best doctors and healthcare practitioners can do is to give you the necessary support. They will give you oxygen if you need it, fluids, any term or any sort of medical treatment and care that you need. They will provide it to you to ensure that you recover and that your you get well as your body fights the virus out. So please call the hotline 6666 and do not refuse to be admitted at the IDU if they tell you that you need to be admitted. And maybe just to conclude, because I may need to rush out. As a conclusion, I know that our numbers are dropping again. We've been through 2 waves of COVID-19 in South Sudan. The second one was more brutal than the first. We may go through a third wave. Just because we are recovering from the second wave doesn't mean we may not go through a third one. Many countries have gone through a third wave. So I call to the people that please do continue to adhere to the public health measures. We've seen great improvement with people wearing masks and washing hands, refusing to shake hands, refusing to greet each other by means of handshake. So let's try to maintain that until we ensure that we have a good number of population vaccinated and that the pandemic worldwide actually dwindles and hopefully is controlled and we don't see any mass fatalities. We are lucky as a country to have low figures actually, and let's use that to enhance our positive behaviors instead of being ignorant and saying, oh, coronavirus is not here. And maybe the other message is that I do urge and I do call for our government to also ensure that we do get options of other vaccines as well. AstraZeneca is one of many vaccines that people can take. We have Moderna, we have Pfizer. So if our country can ensure that there are other options of vaccines to vaccinate other categories of population, it will be great. We see countries using AstraZeneca, for example, for people above 50. And this is the reason why we have a large vaccine hesitancy right now in South Sudan. So at the end of the day, all the vaccines have the same objective, which is to reduce the severity of your illness, to reduce the risk of you dying as well. And also maybe a myth that people may not understand is that the vaccine may not necessarily protect you from getting the infection or prevent you from transmitting it to other people. But however, it will reduce the severity of your illness and it will reduce the chances of you dying from this virus. So let's all go and get our shots. I got my vaccine shot on, I think just under a week ago. I received my AstraZeneca shot and my mother as well. So let's go ahead and let's also call for our government to ensure that other options are available so that people are more open to getting these vaccines. So yeah, thank you very much.
Thank you, Dr. Sandra, for your concluding remarks. And to our people, there are some comments here that I would like to address. Lisa Nelson Michael and Achu Jeffers, they have asked the question whether the vaccine has expired, and they want the vaccine expiration date and the manufacture date to be shown. Lisa and Achu Jeffers, the vaccine has not expired. We will not harm our people. The government and the people in the medical profession are the first line of people who are going to be vaccinated. إحنا ما حنضر أهلنا وما حنضر الناس اللي في مجال بتاعة الطب. لو الدكاترة بتاعنا اللي قاعدين يعالجوا الناس قاعدين ياخدوا تطعيم، يبقى التطعيم ده لو حاجة بتضرنا ما بنخليه، ما بندي للناس. التطعيم ده لسه سار المفعول بتاعته ولسه شغال كويس. خلينا ما نطلع كلام الما صح. التطعيم ده كويس. Dr. Sandra, we can excuse you. Thank you very much for taking the time to be part of the panelists. Dr. Alice Igali Ladu, could you give us a conclusion? And maybe this time in Arabic, if you can.
Thank you, colleague. شكرا لكم عشان تكون نادانا في أنا بجوني عن برنامج كوفيد في ساوث السودان. colleagues تاي كل ونسوا زمان تاي ونسوا عن كوفيد في ساوث السودان. في شغل كتير أنا كمجتمع أنا بقدر أشتغل، مش نبيسيبوا حاجات كله للحكومة، لكن أنا كمجتمع في دور كبير أنا بقدر أعمل عشان أنا بقدر أوقف ولا أنا بقدر كنترول كوفيد في ساوث السودان. إنه أنا كده أتهيأ ل public health measures، ناس كده يلبسوا ماسك. إذا كان في كونيا تبلغوا احتمال في نفرين ثلاثة بس يلبسوا ماسك. أنا دي كم مرة أنا برا كونيا بينا دانا كورونا. So في استيغما من كوفيد في مجتمع. So كده نلبسوا ماسك، كده نكسلوا إيدا، كده avoid، كده مرة في مناسبات. أي في مناسبات ضروري تبرا، لكن تبي شوية تكون ديني بيدين من ناس. حاجة تانية الناس وين يسووا كلام تفاكسين. فاكسين ده مهم شديد، وزي ما حسد أنا وين يسوف بس 2000 نفر تقريبا يشيلوا فاكسين، ومعظم الناس اللي هم فرونت لاين هيلث كير وركرز، الناس اللي بيشتغل في مستشفيات، في مراكز صحية، راتكم يشيلوا فاكسين ده. فاكسين ده في مستشفى جوبا، في مستشفى جيش، في مستشفى بوليس. ما في زول بمعنى تكون إذا بس براتة بوريك أنت بيشتغل في هذا المستشفى بوريك فاكسين ده. حاجة تاني أنا زولت سيرفيلانس. حاجة تاني عندر وينيسو أنا ندو surveillance system في South Sudan. It's called IDSR. I will talk in English, then I will translate. The IDSR surveillance system in South Sudan, which is used in most of the African countries. South Sudan is one of the countries which is using it, the IDSR strategy, and we have an EOS system where we are receiving reports from over 1,230 functioning health facilities across the country. We know, yes, there are some areas where there is no presence of the government, but we have partners who are supporting us. We have a big role as a community because we have one of the surveillance system aspect is the active surveillance and the passive surveillance, the sentinel surveillance. We have what we call event-based surveillance, where the community can really participate in reporting cases of COVID in South Sudan. It's only for the community people, the community personnel to go to any nearest health facilities and report that we have a case in the community. The health facility people will take that up. We have the community health workers in the community. We have the Boma Health Initiative healthcare workers in the community who can also help. So we don't leave this only to the government and the healthcare workers. We at the community also, we can use the 6666 line to call which is very, very active. We have more than 20, 30 people who are receiving calls day and night. So in Arabic and Kengali, surveillance dema bisibu barao le hukuma. أنا كمواطنين بقدر ساعده إنه أنا بقدر ريبورت إنه في cases لأقرب health facility أو تبدوكوا ل 6666 especially ما في محلات كمدن زي جوبا برضو في بلد أهل تتنا في بلد في أي بلد في زول مسؤول زول تاع صحة مسؤول تكون بقدر وريله كان في تكون عنده كيس ولا تكون عنده زول تكون بي سسبكت قالي كيس من بقدر ريبورت لأي health facility ولا 666 بيجشي من بيجشيلوا ناس. حاجة تاني اللي أنا داير encourage ناس كده ناس كله برضه ساعدوا فوقه إنه كوفيد ده حقيقة يا جماعة. ناس بيجين قالي كورونا ده كده كوفيد is not real but كوفيد ده حقيقة. وفعلا في ناس كتار موتوا بكوفيد، عندنا زملاء موتوا بكوفيد، عندنا ناس جيران موتوا بكوفيد. أنا بكده إسكرنا حامي جسم تاعنا كده عنا حامي ناس تانيين بينونا بقدر أسمع كلام الحكومة. أي لوك داون ده أرفع فوق. سيبوا قال فيني ناس كده عملوا مناسبات، ناس كده عملوا أي حاجة، لكن برضو أنا كده أقدر حامي جسم تاعنا بإنه مناسبات كان بعملوا كده يكون في فرق بتاع متر ولا 2 متر بين زول وزول. ناس كده استخدم ماسك دي نعرفه غالي، لكن في ماسك البام بكتين دي لازم زول كده يلبسوا، زول كده كسلوا توالي، ناس كده كسلوا إيدا، ناس كده avoid سلام. في حركة ناس بيسلموا إيدا زي دي برضو ناس كده avoid بس كلمة السلام عليكم. في بداية بيكون صعب لكن ناس بيجيني علموا حبة حبة. I think this is what I have for now. Thank you.
Thank you very much, Dr. Igali. Dr. Anne, if you could please conclude in like 2 minutes.
Thank you, Dr. Akwet. I will try and keep within the 2 minutes, but there are a few things I'd like to mention. I'm sorry I won't be able to translate into Arabic. I haven't been in South Sudan for very long, so I'm not very fluent. However, the things that I need to mention are this, that the vaccine hesitancy is real. As a pediatrician, we actually come into contact with a lot of vaccines because most of the vaccines are given when in infancy to protect from many infectious diseases that affect children. And there have been very many success stories from vaccination, including smallpox, which was eradicated from the world. And we are on the way to eradicating polio and possibly measles. And what I need everyone to understand is that vaccines go through rigorous study and rigorous close monitoring in terms of safety and dosage and effectiveness. And even after a vaccine has been authorized for use, there is continued surveillance, which Dr. Alice knows a lot about, on the side effects and possible adverse reactions that might occur due to those vaccines. Now, as usual, whenever we consider the advantages of something versus the disadvantages, you always have to weigh the benefits versus the lack of it when you're comparing drugs, when you're comparing vaccines. And I would say for vaccines, the benefits do outweigh any other effects that might occur. And most vaccines have just local side effects that many people report with various vaccines. However, of course, there are those specific individuals who might have adverse reactions to vaccines. However, what I need everyone to know is that vaccines are basically biological substances. There are no microchips implanted, there are no implants put in, there are no contraceptives put in, and there's a common misconception that vaccines might cause infertility. However, I would like to say that up to date, there has not been shown to be any vaccine that causes infertility. And there are so many concerns and myths flying around about vaccines. And I want to talk to the public right now and tell them that you have to be very careful what information you internalize, because people have various theories that are not necessarily based on fact. And of course, for us, we are lucky in the sense that we understand the science. However, individuals out there who do not have access to that information do not understand the sciences. So at basic level, a vaccine is a biological substance that is meant to trigger your body to fight an infection so that you're ready. The next time you encounter that same disease-causing organism, you're able to fight against that infection. And this then prevents you from getting either the disease or decreases the severity of the illness. So when you're getting information on myths and things that people are saying about vaccines, you have to be very careful that they're based on fact. Of course, with the adverse reactions, surveillance continues and will continue for a very long time, because anytime any new drug or any new vaccine is introduced into the community, then you have to monitor for these reactions, because there will definitely be that individual who has a certain predisposition to developing an adverse reaction. And of course, for those who develop those adverse reactions, I would advise that you report those adverse reactions, so the monitoring continues, and if need be, then certain things are pulled out from the community, or certain instructions are given in terms of the kind of people who can get particular vaccines. As Dr. Sandra mentioned, in certain countries now, they're only giving the AstraZeneca to those above 55 years of age. But we know that in our setting and among our countries, that we do not have the luxury of choosing which vaccines come, because we don't have the resources to actually get these other vaccines, even though, of course, we implore that the government is able to do that and acquire these other vaccines. So people who are predisposed to certain reactions to vaccines, like the clots that Dr. Sandra talked about, are able to be given alternatives. Now, the other thing is that about children, we have to realize that, yes, children get mild symptoms, but there are those who actually will develop severe disease. And therefore, we should not be lax when it comes to our children and practicing those preventative and control measures related to children. And even as people try to think about opening up schools, you have to ensure that you are able to put measures in place to prevent the spread of the virus. And to our government, I implore that education and emphasis on public health control measures has to continue. Education on the vaccine has to continue, and to ensure that we are able to help our population and prevent the spread of disease. Thank you so much, Dr. Akwot, for giving me that opportunity. And I hope I have been within the time limits you set for me. Thank you.
Thank you very much, Dr. Ann. That's okay. I understand you have always been a moderator, so they say anybody who talks, you give them the mic, they will take it away and do what they do best. So thank you. Thank you for that elaborate answer. We needed to hear that. We have come to the conclusion of our program. I would like to tell our viewers that COVID-19 is real. It is not a joke. All of us have either a relative or a friend who has died from COVID-19. Wash your hands, use social distance, avoid going to social gatherings and even funerals. Ministry of Health has a bigger role to educate the community, to talk about the vaccine that people are hesitant about. Everybody in the medical field, it is your duty to educate your community. It is your duty to be a role model. Be out there, wear your mask. Be out there, talk to people. Use simple language. زي عربي جوبا عشان تبوري للناس يا جماعة كوفيد ده حقيقة ما حاجة ناس قالوا بيه مرض ده جي قتلوا ناس أي زول حسد نعرفه زول عنده أحلته موتوا زول عنده سابيته موتوا بكورونا فيروس عشان كورونا ده كده فوتوا ده نعمل دورنا كده نعملوا حاجة المفروض إنه بكسر اليدين تنا في السودان ما في هاند سانيتايزر في محلات كتير ناس اللي عنده كي تستعمل كدنا ما سلم بعدهم كدنا ما روح في محل كرامات محل بكايات كنيسة كان انت روح فوقه جني مسافة تاكي كده يكون 2 متر كدنا وري للناس حقايق عن التطعيم أنا القدامي تكون ده أنا أكتا تطعيم وما عمل آثار جانبية ما الناس كله ياو بتأثر به يس في ناس جوري قال في ناس حصل لهم جلطة وفي ناس ما بتجيهم حاجة. نسبة الناس دي كم؟ 6 ولا 8 تنفار يا جالهم من جلطة. أي تطعيم عنده آثار جانبية. ما الناس كله ياو تطعيم ده بأثر مومن. ناس تانيين ما بحصل لهم من حاجة. للناس أنا ألقى عينه أنا أرودته شكرا. لدكاترة أنا دكتور آن باتيا لومولي، دكتور أليس إيغالي، دكتور ساندرا بانكس، دكتور جين، وحتى دكتور مدام عايشة الجي عمل برنامج أنا ده، وحتى الناس الجي ساعدوا في مكتب يو ان في جوبا. أنا ده أريدكم شكرا شديد. كده ربنا بارك تكون كده تكون يوز كده تكون استعمل مخك كويس، لأنه حياتنا ده مهم. شيلوا كلام الكويس وامشي بو قدام. حاجة الأخيرة اللي أنا بقول لي تكون يا جماعة، الليلة كان قال لي أنا عندي كورونا فيروس كده، أنا مرة اشتري ورقة الفيك. أنا أعرف حاجة دي بيو برا في جوبا وفي دول كتير كمان، ما جوبا براو، حتى في كينيا حتى في إثيوبيا حاجة دي في كده. ما أكلم للناس أمشي شيل حاجة الفيك ده، ولا الناس اللي في مطار كده تكون ما خلي الناس طلع اللي عندهم كوفيد 19. لو زول عنده كوفيد 19 قاعد في جوا طيارة فوقه كم نفر، إتم بيجيني 17 ساعة 21 ساعة، إتم جي سافر مع ناس ده، إتم بينتشر مرض لناس تانيين. جيني فترة تاكي اللي إتم المفروض بيجيني بودة ما تشتري فيك results الموري قال إتم نيجاتيف، وفي حين إنه in reality إتم عنده كوفيد 19. إتم معموله دكاترة ولا ناس شغالين في مجال الطب ولا أخوان تنا. بده I would like to say thank you for tuning in. God bless you. Stay safe, and COVID is real. Thank you, Madam Aisha. With this, to our esteemed viewers, I would like to say thank you and have a good day, a good morning, and a good afternoon. Wherever you are in different parts of the world, remember it is our collective duty to educate our community, to educate our people, and give them the right information. Have a great day. Bye-bye.
Thank you. Bye.